Good afternoon and welcome to FormFast's Rack Readiness Web Seminar. I'm Ed Corba, your host. Our guests today are Scott Fuller. He's Director of Application Services and Business Intelligence for Doctors Hospital at Renaissance. Doctors Hospital at Renaissance has been featured on CBS, ABC, NBC, and the BBC. When it comes to the actual rack audit process, these folks are experts. They've been through it. They're experts on rack readiness. Also joining us today is going to be Sean Curtis, Director of Marketing for FormFast, and he will be giving you a demonstration for a few minutes towards the end of this seminar. You know, the key to today's recovery audit contractors and management of the process is workflow. Many solutions are available today, but they're not true workflow solutions. This rack readiness seminar today is going to show you how to manage requests and timelines while improving your entire team's communication across your entire enterprise. Then the ability to add the process to the EMR seamlessly makes it priceless. So let's welcome these two gentlemen today, and let's talk about recovery audit contractors and the impact on all of your hospitals. Scott, welcome.
Oh, well, thank you. I'm glad to be here. Let me kind of start by just talking about, for those of you that may not be aware of what the revenue audit contractor program is, or perhaps some of the detail and history behind it. Let me just spend a little bit of time just talking about that before I kind of get into what the concerns are currently with the program. The revenue audit contractor program is started back in 2003. The Office of Management and Budget estimated an improper payment rate of 10.3%. They started looking at this, and they said that we need to mandate a system, a program to investigate and collect over and under payments. And so with this started a 3-year demonstration project. The 3-year demonstration project included 3 different contractors, the actual people doing the audit, and it involved 3 states, California being the largest state. During that time, they looked at claims from just October of 2002 through September of 2006. So they were looking for over a 4-year period of claims. The RAC contractors, the people actually doing the auditing, they created and developed their own proprietary software to help them sort through millions and millions of claims that they were looking at during this duration. And as a consequence, they sort of fine-tuned that over a period of time, and I'll get into that a little bit further on in the presentation. Right now, we're looking at the situation where they're mandating the RAC to be in all 50 states by next year, 2010. And one thing to keep in mind, and this big motivating factor behind all this, is that the RAC contractors are a contingency fee type arrangement. So they only make money doing this by finding overpayments, and they are allowed to keep a certain percentage of that, and we'll talk about that percentage in a little bit. Just to give you an idea of some of the dollar amounts that we're talking about this is just during the demonstration project. There was over $1 billion in improper payments. Well, that $1 billion did include about $37 million that was where they did find underpayments. But the vast majority, as you can see, is $980 million was in overpayments, and that amount of money was taken back away from the providers during that process. So the very bottom bullet here shows there's a little over $200 million that was actually kept in contingency fees by the Iraq contractors. So there's some pretty big money involved here. And again, these numbers are for the demonstration project, and they were just 3 states, and this was when the Iraq auditors were just beginning the process before they even really honed their skills. I think this slide kind of shows that story a little bit. Maybe a little hard to see all the breaks in the years, but basically there you can see in the very beginning of 2006, as to compared to where this ends in the second quarter of 2008, the amount of overpayments collected by quarter basically kept growing and growing the entire time. There's a very steep curve here. This curve is expected to continue on now with the permanent RAC. They've only gotten better at going through the claims, finding issues, and recovering money. And this is a big money, big business for them. And they've had this much of a head start on the rest of us getting prepared to do these collections. Here's looking at, again, this is during the demonstration project, the overpayment by provider type. As you can see, the vast majority, over $800 million, is inpatient hospital setting. That's the lion's share of what they're looking at. But you can see there's other amounts represented here, all the way down even to ambulance and lab services, sharing pretty much the smallest slice of that pie. They've just recently announced during this last year that they are going to be focusing on the hospitals the most during the initial launch of the permanent RAC in the different areas. However, this slide just kind of gives you a little idea that even at the physician office level, that what the type of issues that during the demonstration project that they're finding. They did find $19.9 million in physician overpayments. That money was collected and pulled back out of these practices. And, these areas up here on the top part of the slide represent the areas where they found, the most money. And a lot of it seems to evolve around, pharmaceuticals and different types of testing that, may not have been authorized or allowable. And fortunately, I guess for the physicians, they're not going to be as big of a target when the RAC first launches. They certainly will be involved, and they could be involved when they look at a claim, and this claim may involve a patient that also received quite a bit of services at the same time as they received services at a hospital. They will be able to kind of continue on and look at the physician's claims and everything related to it. So even though they're perhaps not going to be the primary target, they will certainly be a item of interest at times. And eventually, as they handle the hospital setting, they will be going into the physician offices as well. Here on this slide, these are the top areas for inpatient hospitals. This is where hospitals are most at risk, and the things that as a provider, things that we need to be looking out for, where we're apt to lose the most money. By far, 62% is medical unnecessary service or setting. There's just a lot in that, and there's that can mean quite a few different things. But it's, as you can see, it is the biggest slice of this pie. DRGs, either due to wrong diagnosis or wrong procedure, also add up to a pretty significant amount of the pie as well. As you can see, this 62% is over $500 million associated with the demonstration project. The RAC has been divided up into 4 regions of the country. The regions have been labeled A, B, C, and D, and with each region, there is a contractor assigned to that region. For Region A, we have diversified collection services. They're out of California. They have one of the higher contingency fees. It's 12.45%. They've been in the debt recovery services business for quite a while. For Region B, we have CGI Technologies and Solutions. Interestingly enough, they're based out of Canada, but they're a very large international firm. They have 100 offices across 16 countries, so they're a very good-sized firm, and they have a 12.5% contingency fee. Conley, Region C, which is Texas, where I'm at, they were one of them that were involved, and one of the most successful ones involved in the demonstration project. They collected more money than any of the other ones in the demonstration project. They have the lowest contingency fee of just 9%. However, what they are maybe missing out in a percentage they make up for in volume, because they really do recover more dollar amounts in the demonstration than any of the other RAC contractors did. And then finally, in Region D, we have Health Data Insights. They're fairly new. They're venture capital funded, and they're based out of Las Vegas, and their contingency fee is just under 9.5%. The scope of the permanent RAC, originally it was going to go all the way back, and then they picked a few different dates, but what they've locked into and they've committed to is the maximum look-back date is October 1st of 2007. So even though this program is starting in 2010 for a lot of areas, you're still having to deal with 3 years of backlog of claims that they are going to be eligible to look at, and they're going to want to dig through. These RAC contractors, they all have certified coders, and they have a medical director associated with them. They have experienced medical personnel either on staff or on contract to help determine medical necessity. And again, they're looking at it from, sort of a devil's advocate point of view. Again, because they're contingency based, they're going to be very aggressive. They're particularly going to go after the larger dollar claims, where there's a lot more money, for their efforts. Pretty much that's all I want to cover on this slide. On the next one, I guess it's important to understand that the RAC has been a work in progress. The rules have been upheld, but we've been sliding dates over the last couple of years. For the Texas region, we were supposed to have our permanent RAC originally in February, then they slid it to March, then April, then June, and now it's been pushed out to the end of the year. It will happen. It needs to happen, and there's certainly, I think, with the current administration, a lot of focus on Medicare. And we are going to see this RAC in 2010, but it doesn't mean that it's going to be up and running in 100% in all places by January 1st, which is really kind of a blessing in a lot of ways, because the vast majority of providers that I'm familiar with have been a little slow getting ready for this. Ones that have had experience in the demonstration RAC or have personnel who have had experience in the demonstration RAC are very hip to what's coming, and they're preparing. But I do think that this delay is good for our industry in the sense that we can further prepare ourselves for what is coming. A little bit about the different types of RAC claims. Basically, there's an automated claim and a complex claim. Simply stated, an automatic claim is a claim that's going to happen without any human intervention at all. Their software is going to take a look at a claim. They're going to look for certain factors, and something's going to trip a switch, and they're going to deny the entire claim, and the provider will find out about it in their RAs. An example of this would be they can look at a certain CPT code, a J code, having to do with pharmaceuticals. Perhaps a patient was in the hospital for 5 days, and they received, according to the bill, 10 doses of this certain medication. Well, they know that this certain medication, 10 doses in 5 days, would be enough to kill the patient, so they automatically are going to sense something is wrong with that claim, and they're going to send out the denial and retrieve the money right away. You still have a chance to appeal, but it's an automatic claim. They're just going to reach out and take the money back. A complex claim is a little different. They're going to look at the coding aspect, certainly the medical necessity and the setting of the claim, and it's going to be a lot more involved. Particularly like in coding, they're looking for the wrong principal diagnosis. Was it coded too aggressively? Was a wrong procedure code used either through somebody perhaps trying to be aggressive with coding, or just simply by error, or for that matter even a typo in the process. And they're going to look at that, and that claim will come back with explanation as to what they're looking for, and you have a chance, a 45-day window to look through and try to make a determination to appeal it. And we'll talk a little bit more about that workflow in a little. There is a limit as to just how much they can demand from us in a particular time. For inpatient hospitals, it's 10% of your average monthly Medicare claims for a maximum of 200 per a 45-day cycle. So as many that you have going on in 45 days, just a continually looping 45-day cycle, they can only have a maximum of 200 for just your inpatient part. Now, an outpatient hospital or any other Part A billers, it's 1% of your average Medicare services for a maximum of 200 claims per same 45-day cycle. Here's the breakdown for physicians. It doesn't seem like a lot when you're talking about 10 medical records for 45 days for a solo practitioner, but when this is on top of perhaps what the physician already has going on in his office, that can still be quite a load to handle when it comes to pulling all those records. Fortunately, I think physicians are being given a little bit of a break here. They're not going to really be looked at as heavily as the hospitals were for quite a while. For example, the hospital where I'm at right now, we have 500 beds, we have inpatient, outpatient services, and we also have about a 100-bed rehab unit. We're expecting a claim volume of somewhere in the neighborhood of 450 claims per 45-day cycle. That's the volume that we will probably be maxed out at. And certainly in the initial stages of this, I think everyone's expecting the volume demands to be very high. Because of these delays that we've had launching the permanent rack, the contractors are very anxious to get things rolling, and they have, again, 3 years worth of backlog to look at. They're just going to request as much as they can. It means different things to different providers. So I'm just kind of right now focusing in on hospitals, and there's probably a lot in each of these different bullet points. The main area again is medical and necessary service or setting. It represents 62% of the rack takebacks. This is where they were getting the most money from the hospitals, and so these are areas that you want to look at. Your Pepper reports, finding out where you may have some issues, and also your 2-day stays and your 3-day stays. These are another really hot area. The DRGs, There's certain DRGs where you get 26% of the takebacks. Certainly any DRGs that get changed during the course of the coding process. I know, like there's DRGs like 243 and 143 have been very high on the hit list of takebacks, as well as 515, 127, and 124. These are all very popular DRGs. They're also going to look at DRG transfer analysis. Where did these patients go? And medical unnecessary edits, the ones that are automated. And again, your 72-hour rule. You need to look at this next slide. I just want to share with you a little bit about what our organization, what we're doing to prepare for the permanent RAC audit. And I realize there's a lot of little boxes here, and it may be hard to see everything. So I'm going to grab this little laser pointer. Hopefully this is working for everybody. This upper box up here that I'm kind of circling, this is when we have the requests come in. These are the 450 requests that we're expecting to see. We're going to log them into a system. We're going to scan and pull the medical records. We're going to start the review process to make sure they're complete, and then we're going to send the medical records off. This step is now become necessary. Originally, a lot of people were asking why we were scanning it, because we were choosing to use the scanned medical record as part of our RAC defense, being able to flow that electronic document through our hospital. We are not in a situation right now. I'm sorry, my phone dropped a second. We are in a situation right now where we are moving towards electronic medical record, but we're not there yet. So what we need to do is take our medical record, scan it, get on a system to where we can be able to share it within. However, originally the RAC auditors had requested the information be sent to them on paper, and a lot of people were kind of shocked at that, because it just, you just wonder how many semi-loads of paper are going to show up at these contractors when all these documents and medical records start coming in. So someone over there finally said, no, I think we're going to want those electronic. And so fortunately that worked out well for what our plan was, is because we're going to have them scanned in, and we were hoping we could send them off electronic, and it turns out we are going to. The details as to how that medical record, what makes, how they want it electronically. Right now, it looks like all the contractors, I see everybody saying that PDF format is acceptable. Each contractor is going to have their own rules, which they will be contacting your hospital with when they initiate the RAC process. So, there's other choices as well, but PDF seems to be the standard. Anyway, back to my chart. We have, after the review, we send all that information off. The RAC then takes all this information and does two things. One is it can trigger an automatic collection. And so then we're going to find out about it via our RA process. And so the business office is going to get that information, and then we're going to flow that in through the contractors. The other way is they're going to look at it, and they're going to find some medical necessity issues, things of that nature. They're going to send us a letter saying, we're choosing this one for what's called a complex review. That's going to get entered into our system. If you notice here, everything kind of funnels through our RAC coordinator. We are going to put a person at the helm of this, and this person isn't necessarily associated with the business office, but for us, that's where they're going to be positioned. But it's kind of important in these RAC audits to understand that it's not just a business office problem or a coding problem or a medical records issue. This is going to involve all these departments in order to defend an audit. As you can see here, the next step for us is we're going to quickly verify that the medical record is online. and then we go into our review process. And this can involve any of these departments: coding, business office, medical records, utilization review. If it's a situation where we need to recode the patient from back out to from outpatient to inpatient because perhaps we did make a mistake, so we can make that correction as we appeal. And it can involve any other departments, which can include physicians, because if it involves maybe some clarification on some of the notes, it's going to involve the physicians. All this, again, comes back to the RAC coordinator. All these people together make the decision whether or not we're going to appeal. It comes to the RAC coordinator. If we did, in fact, make a mistake and we're not going to appeal, we want to settle up. And we want to do this by the 30-day mark, because if we wait beyond 30 days, in addition to the claim, we are also going to be hit with interest. The interest starts at 30 days, even though they give you 45 days to make the decision. If we are going to appeal, it's first-level appeal, it's basically sent straight out. And this is the vast majority of first-level appeals. And there, again, you're waiting for the RAC to take it and to agree whether or not this is if they agree with your assessment as to your grounds for your appeal. If not, they will send another letter, and this will be a level 2. It goes back through the whole system. The only difference is that when you start dealing with levels 2, 3, and 4, for us, we're involving our legal department. You're dealing with those levels. You are going level 2. You're going to a contract, basically like a mediator that's been trained in this. Levels 3, 4, 5, you're actually going to a courtroom setting. So at anything above a level 1, you're going to want to get some sort of legal involvement just for some guidance. Again, this is just sort of the process that we looked at to defend ourselves, looking at experience that our staff has had with different RAC audit demonstration projects, and in spending a lot of time talking with other providers and how we can best defend ourselves. Kind of a key point I want to mention as well. There's a lot of people had originally looked at this and said, well, we can probably just log this all into a spreadsheet, and a spreadsheet will be a really good defense tool for this. Here's the problems why a spreadsheet won't work. One is the volume. Again, a 500-bed hospital, even 400-bed hospital, you'd still be looking at 400 requests every 45 days. That's just a lot of volume. That's a lot to be logged into Excel. And believe me, I'm a big fan of Excel. I've actually written books on Excel, and I use it daily. But it's just there's some things it's just not designed to do. For you to put all this volume on it and try to share it on a network with as many people that would need to be looking and updating that spreadsheet, you'd just be running into trouble. Plus, really to do a good job of RAC defense, there's also a little bit of offense required, and that involves us to be proactive and not reactive. We need to take a look at what you're winning and what you're losing, what your relationship is with the providers. We know because of where the permanent RAC is starting and how the demonstration project went, that we kind of know the areas where there's the biggest weakness. But every contractor and every organization will have their own particular trends. And a spreadsheet's going to be very hard after you're 6 months or a year into the RAC audit process to go back and sort of analyze your own information. You need a better tool, something that's stronger, something that's going to allow you to analyze that. That way you can look at the areas where you're weak and firm them up. Spend a little more time doing the reviews before you send the claims out initially, and that will have a positive effect on your RAC audits. You'll see a decrease in your claims. Workflow. A single department cannot be solely responsible for responding to RAC requests. It's just in a hospital setting, it's just not possible. And in order for things to be a collaborative effort, you all need to be working off the same sheet of music. And depending on interoffice mail, and all the aspects associated with just communicating as it is in a hospital when everybody else has a lot going on, you need a workflow tool, something that will allow these RAC requests to be looked at simultaneously yet collectively. And then finally, the medical record really needs to be electronic. One, for the submission reasons, but two, to enhance workflow. You need to be able to take that medical record, group it together with the workflow tool to where everybody who is looking at it, looking at the different notes, also can go back and look at an electronic medical record, so they can go back to the original source and actually see what people are talking about. And that's going to be a key to, again, trying to handle the volume, dealing with so many claims in such a limited time frame. These are generally considered the 10 steps of surviving the RAC audit process. One is you need to define your risk areas. Find out where you're vulnerable, and what people are going to be looking at during the RAC. What's your contractor going to be looking at? And then you need to quantify these potential issues by doing data mining. Take a look at the dollar amounts associated with certain DRGs and things like that. You need to develop a RAC response team within your hospital. Again, this cannot be a single. It cannot be a single department. It needs to be a large group, several different disciplines within your hospital, and you need to even have either some physicians or some liaisons to the physician community on your response team. You need to identify the resources needed within the hospital. You want to establish a process. Start thinking about how you're going to move these requests through in a timely fashion. You want to review every demand, and you want to have both defensive and offensive strategies. You want to address repayments. Again, this getting back to your response team, it might be a good idea to have someone from accounting and finance involved, so they're going to be aware of that. You want to review your appeal documentation. Some of that, when you're initially contacted with your RAC contractor, they will tell you what they're wanting in that documentation. And then, the last most important step, you need to establish a tracking database. In order for this to be successful, you're going to need to have a database to track it all in. Ended up the slides. I do believe we're going to be taking questions later on, but I think I'm turning it back over to Ed at this time.
You are. As a matter of fact, we're finishing up with the third and fourth polling question as we go through. But this section now starts to show you how to do these things that Scott has talked about. And I'm going to introduce now Sean Curtis. Sean, would you like to begin?
Scott, thanks for joining us today, everybody. And what I'm going to go over, I'm just going to go real quickly over some of the things that we're doing to address the issues that Scott brought up. So Scott touched on what the process is, but it is a very time-sensitive process, and it needs to be tracked. You get a batch of requests. We talked about the 445-day period that doctor's hospital may be expecting. So that's a bulk. That's a big bulk of work that needs to be addressed and taken care of. Not only do you have timelines, but the auditor then has response timelines as well. So this could expire, and you as a hospital wins the case. If they miss any deadlines either. So you want to know that as well. So for timelines and managing the timelines and knowing, like Scott said, at doctors, they've hired a specific person, or they have a specific person who's the command and control center for this. And our product supports that. It supports not only one person, but maybe a group of people across departments or across different sets of your organization. to be able to have this command and control view. We have a dashboard view that gives them the ability to see everything that's open, in progress, how many days are remaining, the status that they're at, different appeal levels, their status, and things like this. So it's real easy to quickly see where you're at. And then, of course, from this view, they can go in and open that and have access to the process controls. So they can go in and go ahead and request more comments, push it to another level, push it to another user for more information. In addition to that, dashboard view of what's going on, you'll also want to know what's happened, what financially and in the sense of risk. How do we know where we're at? Where are we going to be in the next quarter, possibly? How much money is at risk right now? So we have a reporting tool that's built into the system that tracks everything in real time. So these reports are available in real time. You can check anytime you want into the reporting section. You can also schedule those to be run at intervals and also schedule those to be sent to different users. So if you have financial monitors that need to know this information on a scheduled basis, maybe a monthly, weekly, quarterly, however that's set up, these can be scheduled to be sent to those users. So they're always in touch with what's going on. They can also be exported to a PDF so that you can work with these offline, or in an Excel spreadsheet. You can change the data, make your own, not change the data, but change the format of the data and make your own reports and different things like that as well. So we make a great deal of access to the data that you are collecting, so that it's not data that's being collected for just a single purpose of responding. In addition to this, part of what we want to do is help you to understand what your risk is right now. So some of you aren't into this review phase with the RAC auditors yet. And working with Scott and working with some of the statistics that have come out of the trial phase, we've developed a small tool that helps you understand what your risk would be. So when this does get to you, or if you're already in this and you're just finding out about this program and how much it's going to affect you, and you want to know looking forward what your risk is, we have a tool for that. And it's not a tool that we're selling. It's a tool that we'd be happy to meet with you, share that tool with you, help you collect that information, and show you how you can calculate what your risk going forward is. So that's in addition to the product, and that's kind of a service that we're offering. If you're interested in that, let us know through the chat or the polling, or give us a call, and we'll get in touch with you and bring that along. Back to the product of the response and tracking of the RAC audits. So let's say we're into this now. We've gotten our batch of requests. How does this look to our end users? How do they start this process? How do they start our workflow tool? So many of you already use our Fast Flow tool and understand the way it works. I'll just show you real quickly here. We have two different tabs to where you can access your workflow items. So you can access it through a Documents tab, which stores any kind of document that you might have, but in this case we're talking about RAC-specific documents in a RAC category. And you can find that and click the Start button, and that would start the workflow there. Or if you're in a department such as an audit control department, we also have your workflow inbox, and this is how we manage workflows. What we're doing is we're sending information from person to person to person for input and collaboration. So we have a workflow inbox, and we deal with pushing documents. So this is the tie-in between these two screens. We're working with documents and we're working with workflow. And in the inbox, you have a departmental workflow section, so that it's kind of like your favorites list for your department. So you can quickly access it right there without looking through a directory or a catalog of documents. What has basically the interface to the application, where you'd see a screen with information collection parts, where you would start by filling in, what the RAC ID is, what are the initial due dates and things like that. Once this gets started, then the calculations start to happen. So then this starts to feed that dashboard, it starts to feed the reports, and information can be calculated off of this and filled into the system. So the next step is, once you start moving that forward, the first person in this process is, in Scott's case, at Doctor's Hospital, is to prepare and upload the record. Right now they're on a paper medical record. They don't have electronic. So what they're doing is, the first step is to send this to someone in the medical records department to prepare and upload the record. So this is what that person would see in their basically their workflow inbox. They would see a request to go ahead and prepare and upload that record. So as far as uploading the record, we support, if you have EMRs, if it's already electronic and you can export from that, we can use that. So, and if you're in the situation where a doctor doesn't have that electronic medical record, we also tie in with scanning software so that we can input those documents into our system so that it's a staging ground and it's a collaboration environment for you to work with. But once you've gotten those documents in there, into the system, and now they're sent off as well, so now it's into one place, you've sent these off to the RAC auditor, they're going to come back and say, of those 400 records, we're going to challenge 280 of those. So now we know which ones we're really going to deal with through workflow. And we're going to keep an eye on the ones that they've requested but haven't yet challenged because they have a certain period of time for those before they expire. So we want to keep a record of that and know what they cannot challenge in the future, and also know what they have challenged and start working with the ones that are challenged. So of course this review letter can be attached to the workflow. It can workflow so they can always see what the primary letter looked like in the original state, but it also gets entered into the application itself so they can see on this initial cover sheet, this is what the next user in line would see in their inbox is basically the interface with the cover sheet that shows the dates and the challenge types and things like that. We want to talk about, again, with the reporting, there are different types of challenges, like Scott had talked about, was the biggest one being the medical necessity. We also support grouping these by DRGs, of course, but then also another level, so you can report by whether it's a coding diagnostics or coding procedure-wise or dosage or duplicate payment, maybe an incorrect discharge code, things like that. So that goes back to the chart of the major types of procedures that are challenged. So you can type these so you can get better reporting off of this through our tool. So again, this is just a larger view of some of the data that we're collecting within that. And of course, the RAC coordinator has received notice that he's being challenged on this. So he determines who needs to review and comment on this medical record. And that's where the collaboration tool comes in here. So we've sent out requests to maybe a physician, maybe a coder, maybe multiple other end users who are involved in this. And we've asked them to summary and some of the procedures. So each of those people may have gotten a request in their inbox, and then they can click that link back to our and what that does is it brings up that record, that stage of this. Now, one thing that is advantageous here is that we allow you to comment directly on a single page of that record. So this record may have hundreds of pages to it, allowing your users to go ahead and make comments, and multiple users can make different comments on that page so that you can compile this appeal letter. Because in the end, what you're going to come out with is a whole summary of all of the comments that have happened on this entire record, linked back to page by page where those comments appeared, and then you'll be able to take that report and all those comments and compile and build this argument, this paper argument that you're going to initially send back to challenge it, and it may be the basis of your legal argument in all the 5 levels. What I was talking about was just this interface for collaborating on the medical record. We're not actually touching this medical record. We're outside of your EMR. We're outside of your paper environment. We're in an isolated area. So this is a kind of a specific tool for this instance of the medical record, and it allows users to go in and type their comments, view the entire page, review it. Over here for the RAC controller, they can come into this view as well and see quickly that because this one has a green icon by it, it means that it has comments. These other ones don't have green; they have a red icon next to it. So on those pages there are no comments. So it's another way to make it faster for that person to come in here, either get the summary report or go through specific page by page and look at comments. You get that finalized report. It goes back to the RAC controller, and then that can be forwarded to either a legal department or whoever it is who's responsible for compiling that final argument into a document and sending it off. And then through the interface, of course, you log when this stage has been completed, when the due dates are, what they are, and then that, of course, feeds the reporting tool, so you can report on what's in flight right now, what's out there right now and not yet challenged. So that's just a quick overview. I know we're running long on time here. I wanted to be done at a quarter to the hour. It's right now 10 minutes before the hour. So I'm going to go ahead and open it up to Ed for thank everyone for joining us.
The primary questions that have been coming in, Scott and Sean, people are asking if there's some type of full-blown demo that is available for them to see, or if there's any way that we can give future demos on this so that they can see it individually. Sean, what's our answer?
Right, yeah, we encourage you to go ahead and contact the sales department here, and we'll hook you up with a demonstration of how this will work. We, of course, want to understand how it works in your organization or how your plan is, and help you with that too. And again, share that risk calculator with you so you can understand what your particular risk might be.
Okay, Scott, do you have any way that you would like to kind of wrap up or summarize this?
Well, I just would like to encourage everyone to, really take this time that, we've been given in this delay of the launch of the permanent rack to, shore up your defenses. It's going to be tough when it comes, but fortunately, we do have some time to prepare, and don't underestimate what might be coming, and don't underestimate the tool you select in defending your organization.
You can reach us through our telephone. You can contact us by email. You can also fax us, or you could go out to our FormFast users and join our user community and talk to other end users, or simply email me, ecorba@formfast.com. I want to thank our guests today, Scott Fuller and Sean Curtis, for the information they gave you today. This information comes from folks who know and understand this RAC process. So, on behalf of Rob Harding, John Yock, Sean Curtis, Scott Fuller, and the entire FormFast team, thank you for being here. We'll see you next week.